Okay. So welcome. And this is chapter 14 of the Bouncebacks Critical Care book. And this is our second to last before we take our summer break, which goes through the summer because Labor Day is that first Monday in September. So we start again in October. And we welcome folks, and some folks are watching now, some folks watch the recorded version, but we have a fantastic panel that I really want to thank. And we'll put up our CME disclaimer as well as the code to get CME in just a few seconds here. So I want to first thank, in alphabetical order, Nate Finnerty, Department of Emergency Medicine, Intermountain Medical Center, Salt Lake City, Utah, and Assistant Professor of EM Adjunct at the Ohio State University. Hafeez Hassan at Adina Interventional Cardiology is the interventional cardiologist, the only non-emergency medicine physician here. We have Sarah Stahmer, and Sarah is fantastic. We actually spent some time together at UNC when I was down there just before the last bounce back that she participated again, and she was so good that I had to have her back. Sarah, no pressure. And then Scott Weingart, Chief Division of Emergency Medicine and Critical Care, Stony Brook Medicine. So everyone, thank you so much for joining. We hope to be true to the time that you've given us tonight. And this is an important case because, and I can say this maybe in a little bit of a self-deprecating way, but I love STEMIs like I love zoster. Like in general, you walk in, you see the zoster rash, and it's pretty straightforward what's happening next. And in general, most of the time with the STEMI, it's like you have a clear-cut EKG, you know what to do. If it's during the day, they're going pretty quick over to the cath lab and next patient, right? However, what I want to really focus on today is moving from our standard of care to our excellence in care, like we talked about a lot, but in moving from the standard STEMI management, thinking about what we do when things aren't just exactly right. And for the patient that we had tonight, things weren't exactly right. The patient that we had was a patient who had hypotension, and not just like hypotension, her numbers look a little soft, but she's sitting up and talking to you, but hypotension in the 40s hypotension. So just brief, I told you I'd do this, no financial disclosures, and this is our sort of to be able to get CME. The next screen will be the code you can flash your phone at to actually claim the CME credit, and here it is. And if anyone has a problem getting the CME, they can always, send us an email, and we'll help them out with that. And that is just for the live participants. And this is a screenshot of our expert panelists. Okay. So I'm going to start off by telling you the patient story because all of these cases are stories because these patients are our family members and our friends. And, at some point, if we are fortunate enough, they will be us one day also. So this is a patient who is 70 years old. And in early May, interestingly enough, she developed chest pain. It was initially minimal, but it got worse. She asked her husband to drive her to the ED. She underwent some testing, including labs, chest x-ray, troponin, all of which came back negative. She had an echocardiogram and a stress test in the OBS unit, and they came back negative. She was discharged home and asked to follow up with a cardiologist. She called the next day, but told that she wasn't able to be seen for a month until June. So 1 week later, she'd been doing pretty decent. 1 week later, she wakes up very fatigued, hard to get out of bed, finally making it to the bathroom, brushes her teeth, makes it downstairs where she lays down on the couch, and her husband comes down for breakfast. He finds her there, pale and sweaty, calling 911. When EMS arrived, they perform an EKG, and it shows, and this is not her exact EKG, but it shows a inferior STEMI. And this is like, again, my favorite case, right? The classic reciprocal change type of STEMI. So we sort of know what to do, right? But unfortunately, and I told you this part also, as you'll see, her blood pressure was 51 systolic. So this is the actual documentation on the chart. Nothing's been changed for HIPAA reasons, and even spelling errors are still included. So at 7:12 a.m., she presents with chest pain, but also has, as documented by the emergency physician, shortness of breath, sweatiness, weakness. Today, she developed shortness of breath, felt weak for the last several days, actually, and she was given aspirin by EMS. She said, they said she was so hypotensive, they gave her some IV fluids, and she has a set of vital signs. Here you are. Pulse is 62, her blood pressure 51/40, and they describe her as being pale and dyspneic, anxious, very ill appearing. And as far as her heart exam goes, regular rate and rhythm without murmurs. So what I wanted to do is just sort of jump right in And we're going to start with Nate. First question to you. And Nate Finnerty is the chapter author of chapter 14 here. And so, Nate, I'm just going to ask you this question here. This patient is hypotensive. What are our possibilities?
Yeah, so for the undifferentiated patient, there's an extensive list of potential etiologies for hypotension, but this patient is no longer undifferentiated, right? That EKG suggests that this is cardiogenic. For an inferior MI, depending on the location of the culprit lesion, hypotension could be due to either left ventricular or right ventricular dysfunction. Now, acute MI with left ventricular dysfunction is the most common cause of cardiogenic shock. In that case, myocardial ischemia leads to depression in myocardial contractility, ultimately reducing cardiac output. This initiates a sort of death spiral as sympathetic stimulation increases heart rate and contractility, increasing myocardial oxygen demand and reducing coronary perfusion. Then, as we all know, fluid backs up into the lungs, leading to pulmonary edema, with the next stop being respiratory failure, which is why we are on the clock and want this patient out of the department and off to the cath lab to stop this spiral. Now, isolated RV infarction is less common, but has a higher mortality rate. Proximal right coronary artery occlusion is the most common culprit lesion, and the infarcted RV becomes stiff and dilated, resulting in decreased compliance, reducing filling, and decreasing stroke volume. This leads to decreased left ventricular filling and a drop in cardiac output, even in the setting of normal LV contractility. So, with the EKG we've been presented with, it's most likely one of these two mechanisms leading to hypotension for this patient.
So, Scott, so that would be, in some ways, maybe not necessarily an easy solution, but if we sort of had a crystal ball and we knew that that was what was going on, but there's certainly other causes of hypotension. And as we'll get to in just a few seconds here, this emergency physician, very rightly so, pulled out the ultrasound machine. What are some other causes of hypotension in a patient with STEMI who now we sort of know a little bit more, has had some weakness and fatigue for the last several days and a chest pain evaluation 1 week previous?
Yeah. So obviously cardiogenic shock, but that's not classic, as Nate just said, because the lungs are completely clear. And generally, the picture of cardiogenic shock is severe hypotension, pulmonary edema, this typical left ventricular failure. So, either this is hypotension from a right-sided MI or something else is going on. So the ultrasound would be very helpful to kind of figure out what's going on, look for other causes of hypotension. But if you're going to pin this all on the RVMI, the patient's already gotten fluid loading in the field, and I don't have a problem if you're going to start a small bolus of additional fluid. But the mistake here is to say right ventricular MI equals more and more fluid loading and wait 15, 20 minutes to get in 2 liters of bolus and let this patient potentially go into cardiac arrest. So this patient needs immediate stabilization regardless of any cause. The MAP takes precedence. So this patient in my hands would get push dose pressors. I'd be calling for a norepinephrine drip and start that right away, not at like 2 or 3 micrograms, but all the way up 15 or 20, all in the goal of getting this map to a reasonable place so that we have the time to figure out what else is going on. If your shop is capable, I'd throw in an A-line, and then we could reassess after we started the initial stabilization.
So, Scott, let me give you a little bit of a rubber meets the road sort of question here. Her pressure is 51. You've done all this stuff. Say, for example, and we'll find out in a second what actually happens. Say, for example, her pressure stays low, and we'll also show the ultrasound results in just a second here also. But say, for example, you don't find a reversible cause on your ultrasound. How are you balancing what is certainly possibly going on, like an RCA occlusion causing a inferior and right-sided MI, and the need to get that opened? How are you balancing that with the fact that the patient is hypotensive and, just for example, if she's not responding to the measures you do?
Yeah, well, a few things. One, this patient's going to the lab. So if we really think it's cardiogenic, then before they actually try to open up the vessels, they could absolutely place a mechanical circulatory support device if that's what we think is going on. It's purely cardiogenic shock. This patient is an ECMO candidate in my mind. And, as I'm getting her stabilized enough to go to the lab, I'm going to take precedence in where I'm placing lines such that if she needs to be put on ECMO in the ED or in the cath lab, it's pretty much good to go because the access line's already there. For most of the people in the audience, this is completely irrelevant. You don't have access to it. It can happen. So if I can't stabilize this patient on vasopressors and potentially inotropes, then something else is going on. And Mike, you can't keep making me have this conversation without giving me an ultrasound.
Well, speaking of ultrasound, we do have Sarah Stahmer here, and she is like the cardiology ultrasound guru. So, Sarah, you put the ultrasound in the chest. Tell me specifically what you're looking for and then what you can do with the findings that you get.
Well, again, one of the biggest problems I see is that people are so enthusiastic about using POCUS, which I love. But again, you've got to get the pressure up. As you know, Scott was saying, you have to get the map up because brain perfusion, I want my brain more than I want any other body part. And so you need to make sure that there's perfusion going on. But there's something weird about this case because of the fact that most of our inferior wall MIs we see are RV infarcts and, you know, don't present with such profound hypotension unless somebody gave them nitro in the field or they had some pre-existing condition where their preload was down. So the first thing I would do is do the ultrasound just to confirm the suspicion of an RV infarct. The sensitivity and specificity of echo may be as high as 82% for the detection of RV infarct. That again depends on who's doing the scan. Signs include right ventricular wall dyskinesia and hypokinesia, paradoxical septal motion, tricuspid regurgitation, and pulmonary regurgitation. Most ED physicians aren't able to do that. And so the most common method is just eyeballing the RV and using TAPSE, which is the tricuspid annular plane excursion. And that's an easy thing to use. And those are probably the ones that are most helpful in confirming that this is an RV infarct. Importantly, to recognize that we all look at McConnell's sign, which is sort of the person jumping up and down on the apex of the RV, as being a sign diagnostic of PE, but it can be seen also in RV infarct. So that's something that you may be appreciative of. And the one thing we would see, all of us are pretty good at looking at the IBC. The IBC should be dilated in this case. And so those are things I would do it to say, yes, this is what they have. The ECG shows that. This is my clinical suspicion, and the IBC is dilated. And then you would go on doing what Scott was saying. But the second thing is saying, well, why is she so profoundly hypotensive? And so things that would be worrisome things would be, one, if she has a flat IBC. That's probably the most diagnostic of the IBC findings. If it's flat, they will always benefit from fluid, volume, blood. Looking for a pericardial effusion. Again, we weren't expecting it, but that's something that would be a sign that there's some obstructive reason why the blood can't get out of the heart. And then again, looking at LV dysfunction and seeing whether this was a very profound wraparound RV that caused not only RV, but also LV dysfunction.
So, Hafeez, let me bring you in as the interventional cardiologist. I'm going to put you at the bedside. You're standing there. We're doing all of these things that these folks have talked about with the fluids and the pressors, and we don't have ECMO. So let's just sort of say that because, you know, Scott sort of set the tone that we don't have ECMO at wherever most people are practicing, right? So the emergency physician looks at you and says, let's just get this patient to the cath lab and open up the RCA. When we spoke earlier today, you seemed a little reluctant to take a patient who's so profoundly hypotensive. I'm not talking about for some sort of mechanical device, but just for a interventional cardiology procedure.
Absolutely. Absolutely. No, I agree with you guys. I'm a little bit old school. So when you guys call me for this EKG, and this is clear-cut inferior STEMI, you know, I'm at the bedside, typical triad, patient is hypotensive, patient has clear lungs, and patient has an elevated JVD. All of these things are pointing towards typical triad for somebody who's having RV infarction. You know, these patients are sick, but these patients are not that sick that you have to give them some fluids. If they're having some AV blocks, give them some atropine. These people do get better, but the fact that this patient is not getting better with the fluid bolus and with the pressors, that makes me think that there's something else going on. And RV infarction or RCA infarct on the EKG has been associated with so many complications. Just imagine this patient, she's old female, above 70. This is her first MI, and she's a female, above 70, female, first MI. All these three factors put at a higher risk of having any mechanical complication. Keeping that in mind that this patient came to the ED 1 week ago with a chest pain, although nothing was found. She was sent home, but now she's back after a week. And with this typical triad with RC infarction and hypotension, which is not responding to the fluid. To me,
So let me interrupt you just for half a second. You said a second ago, make us concerned that something else might be going on. What are some
exactly.
of those things that also might be going on?
Right, right. So I'm suspecting either she's having electrical complication, which is very common, AV blocks, arrhythmias, or she's having a mechanical complication. Again, she's a female, she's above 70, that's her first MI. These patients are at high risk of having a mechanical complication when these patients present within 48 to 72 hours. Although we don't see them that often because now patients are coming to the ER earlier, we're getting them revascularized soon. We used to see them in that streptokinase or TPA era when these patients were coming late in the ERs.
So when you say mechanical complication, papillary muscle rupture,
Absolutely.
ventricular free wall rupture,
Absolutely.
septal rupture,
VSD,
valvular problems, all those
exactly.
are
VSD,
things that,
papillary muscle, exactly. All these patients can have hypotension, which is not responding to the fluid bolus and which is not responding to the vasopressors. So I think focus is a very good idea.
Okay, so I'm going to tell you what happens with her. One last question for you, Hafeez. When you think about the emergency physician, for example, saying, let's just take her to the cath lab, open up the RCA, and see what happens.
Yes.
Would
Yes.
you, like, I guess a yes or no answer, would you do that at this point? Or do you feel like we still need to wait, do some more diagnostics and some more therapeutics to get her pressure up first?
Dr. Weinstock, to be honest with you, I'll be scared to take this patient to the cath lab. This patient is not responding. I'm not sure about her pH. What if the pH is 6.9? She has a high lactic acidosis of 10. In the cath lab, she's not going to respond to the levofed. And the worst thing I want is to code the patient on the cath lab table. So I want to take all these things out of the equation before I take the patient to the cath lab. I understand she's in a cardiogenic shock and she will definitely benefit from revascularization, but I'm really scared for this patient who is not responding to initial measures.
Gotcha. So I think the listeners will find it's surprising what happens next. The understandably pacer pads are placed on the patient. She has a chest x-ray, which looks normal. Interesting, right? She has a bedside echo by the emergency physician, and here's how they document the findings. Shows pericardial effusion and possible depressed RV function, but no evidence of tamponade. Heterogeneous material in the effusion noted, though not clear what it is. And so then they say their impression was pericardial effusion without tamponade. Decision to defer transfer to the cath lab based on this pending more comprehensive echo done by the cardiac echo sonographer who is en route. Okay, so the patient has multiple progress notes. I mean, I swear, like every 5 minutes, I didn't really include every single one, but there's another progress note. The interventional cardiologist, just like you, Hafeez, came to the bedside and is there. And they're now also paging the cardiothoracic surgery, and the thoracic surgeon, of course, is in the operating room. Next thing happens, labs come back. Wow, 4.9 hemoglobin and potassium of 1.6. In a patient where there's no history of bleeding, who's not anticoagulated, I don't believe so, and a potassium like significantly low, but without any note that she's on diuretics or anything else that you would expect. So it's an unexpected findings here. And then we repeat her blood pressure after these interventions have been started. And I was sort of giving a little foreshadowing. Now her pressure is 48 over palp. So what I want to do is with Nate, I'm going to bring you back in here. We've given her IV fluid. The emergency physician has ordered some cross-matched blood, but it's not yet arrived. Has our differential changed? Or, and I guess the other part of the question is, how do you reconcile these findings with the patient's clinical condition, and are they even believable?
Yeah, so with the pericardial effusion, now your differential expands somewhat. Aortic dissection should be near the top of that list. You can dissect into the pericardium and have ST segment elevation on ECG. So that's definitely on there. Pulmonary embolism could present this way. We've also talked about all the mechanical complications from RCA infarction. The anemia is a head scratcher, right? Have we missed the mark? Is this actually acute blood loss, like from a ruptured AAA leading to type 2 MI? That's definitely got to cross your mind because we may have anchored prematurely on a diagnosis when we should have been thinking a little more outside the box. But I think it feels like at this point that quick STEMI disposition is getting further and further out of reach, don't you think?
Right, right. That the very quick one that I like to do. Yeah.
Yeah.
So Sarah, let me bring you back in with this echo finding because it's a little bit weird, and I'm just going to go back to it. This is how they read it, showing heterogeneous material in the fusion, though not clear what it is. And so if Nate included PE as part of the things in the differential, well, we're certainly not going to give this patient thrombolytics when we have this finding in the pericardial fluid. So tell me how you reconcile that, or is this just not an accurate read of the bedside ultrasound?
Well, she probably had an effusion that indicates she had a contained rupture, and that heterogeneous material was clotted blood that was floating around. I mean, the only other thing could be is air, and unless she had a percutaneous procedure within the last 4 or 5 hours, it wouldn't be that. So I think she had a contained rupture, and so that's a really decision that we look to our interventional cardiologist to say, what are you going to do? I'm on the other end of my cardiology colleague here in that I'd be looking, I'm 65 and I'm riding horses and jumping huge fences. And I'm like, and she's not over 70, she's 70. So don't put me in that box. You damn well take me to that. I'm sorry, excuse me, that was probably. So I think that this was this was somebody who you start thinking about, what do we do with a contained myocardial, why is she not going to CT and having a patch and opening up that right coronary artery and giving her a chance? If she's a frail looking her age or older, people tend to look, and the management is so often different. And I can just tell you that right now, that we will look, to same age and clinical appearance, and whether they are appropriate for their age has a huge impact. And we also know that women, yes, they're higher risk. I know that, but they also are at higher risk of being undertreated.
Absolutely.
Yeah.
Yeah. So, I'm sure every single emergency physician in the country feels that they treat men and women exactly the same, right? But the data's
bad.
It's not right. It's bad. And then you think of in this situation, and Scott, I'm guessing that you have like a 2-hour lecture to give right now, because there's probably so many things that you're thinking now. But I just want to set the stage. We are sitting here watching this patient die in front of us with like every consultant who's ever trained in anything related to cardiology standing right next to us. Tell us what we should do here. Where would you go with this patient in front of you?
Well, the first thing is, yeah, she hasn't gotten better, but we haven't done anything, at least according to the case. I haven't seen any results of pressors. I don't know when this case was written, but I don't know if they even knew about push dose pressors back then. But it would have been nice to see an actual intervention such that we could say, is she resistant or not? Because what this patient needs is immediate stabilization of a blood pressure. And my guess is if we got something on and something in, the blood pressure would be better. I guess PE's in the differential, but I don't really feel it because there's too much stuff that doesn't go along with it. How did the patient wind up with an inferior and right side and posterior MI from the PE? I'm not there. Dissection is a unifying diagnosis for everything except the labs. You might say, oh, well, maybe the dissection's ruptured and it's bleeding, but we should have picked that up on the rush exam. We should have seen the hemothoraces on one of the two sides to actually explain hypotension. The only other way it's going to give you hypotension that's not cardiogenic shock is if it's spurious, if you're actually on the arm where a dissection flap is knocking off perfusion to that arm. But you should have figured that out on your initial vascular exam. If you had bounding femoral pulses, or the other arm felt good and this arm had a low blood pressure, that would point you towards that. So dissection's still there, but I think the patient probably deserves a trip to CT. If the blood pressure stabilized, then maybe Dr. Hassan would be willing to take this patient to the cath lab once we've ruled out dissection, which I think is the only thing that's really troubling me before I put her on a cath lab table. The labs, I gotta, come clean. We all know about this case ahead of time, but I don't review these cases. I just, look back to the book and I don't remember anything about this case. I looked at those labs and I'm like, these labs are not real. And I'm sure I thought the same thing when I initially saw it, but I'm not saying that because I knew. I'm saying that because I looked at the labs and, not just the ones that were highlighted, the others too, the platelet count, the potassium of 1.6. And I'm just like, this is a specious lab draw. So if you started blood, would it be okay? Yeah. 1 unit of blood in that circumstance, patient's dying in front of you, fine. Would I start potassium at this point? Probably not. I would do an immediate repeat labs, preferably in a place of either point of care or if you have a stat lab or something like that that gets you an immediate potassium and an immediate H&H, do it, because these labs look very weird. It looks like it was a lab draw issue, not a real patient with a 1.6 and a 4.9 hemoglobin walking around normally.
So Scott, I want to nail you down on something, and you and I actually feel very similar about this, because I know we've talked about this in these other times and other conversations also. But this whole narrative, a little bit of a platitude that, people go to CT to die, the circle of death, the donut of death, all those sorts of things. I mean, probably that happens more frequently because you're sending them there because you're concerned about them, right? And in the end, what are we doing at the bedside in the trauma room or whatever room the patient's in that wouldn't be able to be done on the CT table with appropriate people there with her? In other words, maybe the physician walking over, respiratory therapy, you got a nurse or two walking over. And to me, it just sort of feels like, exactly like you're saying, we need a diagnosis here or else no one's going to do anything. I mean, what do you think, Scott?
No, you're absolutely right. Look, it's a remnant of the time where CTs were 3 floors up. They were sent with a transporter, and then, of course, they're going to die if they're sick. Now, CTs are outside our door. We go with our entire team. Would I send this patient at 48 over palp? Of course not. Even I'm not that crazy. But again, she's not been given any vasopressors. So if she stabilizes even to the metastable point, yeah, we're going to take a trip to the CT scanner. We're going to bring our entire team and all the medications we need, because I need to figure out if this is a dissection and get her into the OR if it is. And if it's not, then I'm going to try to beg Dr. Hassan to, once I've stabilized the blood pressure and we have repeat labs demonstrating they are specious, please take this patient to the lab.
Okay, so here's what we're going to do. We are going to find out what happens next. But before we do that, during this special chapter 14 of the Bouncebacks book, we are going to do some book giveaways. And I haven't asked folks this yet, but if each of the 4 of you, and I'll think of one myself, want to think of a trivia question to ask, and then whoever answers that first on the chat, we will send you a copy of the Bouncebacks Critical Care book, and you can then privately or on the chat also send me your address, however you want to do it, mweinstock@mweinstock.com. So there's my email address. You can send me that. So if you guys each think of a trivia, it doesn't have to be medical. It could be, music or politics or, I don't know, philosophy, whatever you want to do. Scott, you can ask for like, what book did you recommend in February of the 3 or 4 books per month that you read? And, always an important thing. So, all right, so let's find out what happens next. And while everyone's thinking of their trivia questions here. So interestingly, potassium was ordered, blood was ordered, and both of those were started, as well as dopamine. The patient's pressure did start to improve. So as far as Scott allowing that patient to go to CT scan, maybe we'll at least get a little bit of a better pressure to be able to do that. And you can see, you can feel, I mean, it's palpable, this emergency physician at the bedside trying to do everything they can. They checked a rectal exam, but there's guaiac negative. So again, that makes the hemoglobin seem unlikely. Blood is checked again, and now, before any significant amount of blood is given, the hemoglobin is 14.2, potassium level is 3.8. So at least those things are off the table as far as some weird type of anemia from a ruptured AAA or something that would have caused the patient to be having a, like Nate said, is type 2 MI, some sort of supply and demand because of severe anemia. So where we're at now is we're still with this weird heterogeneous material in the pericardial fluid. We have an improved pressure, and I can get you that in just half a second here. And we have now normal hemoglobin and potassium levels. So those things are not what's causing the patient the problem. It probably was some sort of dilutional effect. And when we look at cases, bounce back cases and cases of medical errors, we often find that there's 3 errors that occur, 3 or more. And it's sort of weird. It's like, why don't 2 errors occur? And it's always like multiple errors occur. And it probably is the fact that just 1 error wouldn't always cause a bad problem. Or perhaps 1 error, for example, by the pharmacist would be picked up, and maybe that inappropriate or incorrect dose of medication wouldn't be given. So we're going to move to our decision point 3 in just half a second, but let's take a 2-minute cognitive break here, ask some trivia questions. Scott, do you want to go first with a trivia question?
Sure. So, based on the best available evidence, are nitrates still contraindicated in right ventricular MI? First person to answer gets the book.
Sounds like a trick question. Jennifer says yes.
Nope.
All right, we'll see if oh, there are a bunch of no's. So
Well, whoever knows first, because one of the paramedics down in Australia did a review of all the extant literature, and what it was based on seems to be complete bullcrap. And you could check out MCRIT for that post. But I would not give it to a hypotensive patient like this, but I think it's perfectly fine to give nitroglycerin in RVMI. And I think that is now a myth.
okay, so for Jessica Pelletier, if I'm saying that correctly, you are the ultimate winner. If you want to email me at mweinstock@mweinstock.com. I know it's a weird email address. I will send you a book. Nate, do you have a trivia question to ask?
Okay, I like music, so this is off topic. Most expensive guitar ever sold. You're gonna have to search it, I'm sure.
Raymond Milder says Stratus, and we got a Jimi Hendrix Martin D18E from Dave P. Elvis, Nate, any further hint?
It was sold in auction. I just read this article. I'm trying to find it. Yeah, so it was sold in auction. It is a Strat, but it's not a Hendrix Strat. It is from that time era, though. It was recorded by a famous guitarist on a famous album.
The Black Strat?
It's black. I'll give you the album. You can come up with the name of the performer. So it was used to record Dark Side of the Moon, Pink Floyd. So who's the artist?
David Gilmour?
That's it. Yep. David Gilmour Strat. Sold for
All
like
right.
$4 million at auction. That's the one.
Wow. Adrian Gorzitzi Maxi, probably butchered that name, but send me your email address and I will send you a book. mweinstock@mweinstock.com. I mean, your home address to my email address. Sarah, do you want to give a trivia question or you thought of one?
Just because this was brought home to me the recent months of taking care of folks. So over-the-counter medications are frequently viewed as being safe and without toxicity. And there's one that has been associated with severe fatalities that I've seen at least 10 times in my course of 40 years of practicing. And so it is one that tastes really good and can be chugged. And what is the name of that medication?
Are you watching this chat, Sarah, to see, or do you want me to read the answers?
Oh, you can read the answers.
Okay, Tylenol. You can stop me when someone gets it correct. Tylenol, cough medicine, Robitussin, dextromethorphan, Motrin, Benadryl, Robitussin, NyQuil.
NyQuil.
All right, Joseph Barker, you have won yourself a free Bouncebacks book. All right, Hafeez, do you
Yes.
have a trivia question?
Okay.
Don't make it too hard. Don't make it too hard.
No, it's pretty easy
I gotta
actually.
get back to the program.
It's pretty easy actually. So based on clinical side apart, based on EKG, what are the signs that this patient is having RV infarction? Although the RV infarction is a clinical diagnosis, but just based on this EKG, how can you tell patient is having RV infarction?
Raymond Melder says the inferior leads.
Okay, that's
reciprocal changes, ST depressions in the anterior leads. V3 is higher, says Jim Baird. Hypotension, right-sided MI.
lead 3 is higher than lead 2 or AVF. If the ST elevation in lead 3 is higher, that's a sign. The other sign is a V1 elevation. The two signs.
All right. Are you looking at the chat? Do you want to tell me who got it correct?
I'm actually not.
I don't think anyone quite got it.
Right. That's why I was throwing it
It's
back.
too early to throw it away. Okay.
We have Jim Bard saying 3 is higher. than read
Perfect.
3.
Let's
There you
give
go.
it to Jim. Jim, send me an email with your home address. I will ask a very simple, quick question. This is a music trivia from one of my, well, probably my favorite musician. He at one point wrote, "The pump don't work because the Vandals took the handles." In the same song, "You don't need a weatherman to know which way the wind blows." One of my favorite lines. Initials of BD. There you go. Dave P. Bob Dylan. All right. Nice. All right. Edgar Lee, you were almost there in time, although I will say by spelling Bob Dylan's name wrong, you were second and spelled the name wrong. I'm just teasing. So, all right. Okay. Let's get back to the case. So, folks, send me those home addresses or whatever address you want to send, and we'll get those books out to you here. Okay. So here we are with our case. Now a patient had gotten there at 7:12 in the morning. Remember, now it's 9:27. Spoke with the hospitalist. The formal echo is in progress. Floating substance around the heart, not causing tamponade. RV may be slightly less function. And I want to give you guys more because she actually did get a CTA. Was reviewed with the radiologist. She had some amount of pericardial effusion. And the concern with cardiology was that the risk of worsening this with the intervention, and the decision was made not to do a cardiac cath because of the need for anticoagulants. So, Hafeez, we spoke about this earlier today as far as anticoagulation with the cath, and your thought is that that was not really a contraindication, at least with the diagnostic cath.
Absolutely, yeah. I think the only so I'm at the bedside. The only thing I'm worried about is aortic dissection. If my ER physician tells me there's no aortic dissection, I need to help this patient. I'm gonna call it a salvage case, and I'm gonna take the patient to the cath lab, and at least I'm gonna take pictures. So whenever your interventional cardiologist is not agreeing on you, he's not taking the patient to the cath lab, just tell them, just give me the diagnostic pictures. It will tell me a lot more things about the patient. Aortic dissection is the only thing. The reason being, I have done it before during my training. A patient came in, same RC infarction. We went from the groin, and we were in the false lumen through and through, and we actually worsened the dissection. The dissection is the only thing every intervention is afraid of. Yes, this patient needs help, right? And there's nothing else which can help this patient except mechanical support and maybe revascularization. If the RV rupture is there, that thrombus which is holding this RV rupture, it's there. If you're going to give heparin trip, that a thrombus is going to resolve and the patient is going to go to tamponade. But just taking that diagnostic picture, I don't need to give any heparin dose for that. And just giving those diagnostic pictures, taking an LV gram if possible, and just a mechanical support, it's definitely going to help this patient temporarily. And the ultimate decision is going to be the CT surgery. The reason being, this patient is having a mechanical complication, the CT surgery can open up the chest. They can revascularize the patient. On top of that, they can just patch the repair as well. This patient cannot be fixed percutaneously, to be 100% sure. But just for the diagnostic picture, I think it's a good idea, and I will take this patient to the cath lab.
Okay, so you're saying at this point you would have done things a little bit differently than what was done at the bedside here. And obviously this hospital has, interventional cardiology, has CT surgery, has the ability to do echocardiograms, of course. So this isn't like a, rural hospital with no resources. There are resources to do all those things, but you're saying that you would have done things differently than had been done at this hospital.
Dr. Weinstock, everybody's trained differently. Some people are very aggressive and some people are super, super conservative. I'm those type of people who are very kind of on the aggressive side, And when I see these patients, I think we call it just salvage. We don't want the mortality on us. Being an early career physician, I don't want an extra mortality on me. But at the same time, I have taken a note to help these patients, So just taking this patient to the cath lab, just getting more information, just like a diagnostic cath, it's going to tell me a lot more about the patient.
Let me ask sort of what might be a little bit of an uncomfortable question is that all of us, all 5 of us and everyone on this call thinks about, of course, our patients first. I mean, 100%, but there's practice variation because, like you said, some people are more conservative, some people are more aggressive, some people are practicing to their own previous worst case, right?
Right.
How much does that thought that there would be an adverse outcome because you, us, one of us takes ultimate responsibility for that patient, how much does that factor into the decision to take this patient?
Dr. Weinstock, a lot. This patient, according to the SKY guidelines, shock A at the beginning, cardiogenic shock B, cardiogenic shock A, class A means at risk, B means beginning, C means classic, D means deteriorating, and E means extremities. This patient is already at D. He's on pressors and he's in classic cardiogenic shock. The mortality is already 70% to this patient, you know, and some people will see that it's 70%. She's 70, she's not a candidate of ECMO. You know, if the lactic acid is above 10, she's not a candidate of ECMO. No matter what you do to this patient, it's not going to help. But some early career physician or very aggressive people like me, they're like, oh, but there's still 30% chance, you know? So let's call it salvage and let's do it. So it plays a lot of part. I believe it's more than 50%.
And interestingly, it does actually show on the CTA, it shows occlusion of the RCA, which sort of makes sense with everything. So Sarah, you're sort of raising your hands like, yes, that's what I'm saying. I mean, Sarah, I'm guessing you can feel the frustration of this emergency physician at the bedside.
Yes, I can. And so, you know, I've been in, there are a couple of things I just want to comment on. First of all, those labs are so classic for saline and dilutional, as Scott was alluding to, that the people who are on this call really need to look at them because there's non-anion gap acidosis. And that's, you know, that's classic for unless she has all the other things that would put them at risk. And those are clearly things having GI losses, et cetera. And a K of 1 is going to cause ECG changes, irrespectively of that. There's no way it's going to not cause widening up of everything. And so it's just saying they're wrong and not acting on them and not delaying things, but keep pushing, keep the focus on saving this patient. Dissection, you know, I know that you were talking about something you were talking about, but I've been doing this longer than all of you put together. And I've seen, I think, and I've seen, you know, and I mean, I gave lytic therapy in the day of when we didn't do what we just gave streptokinase, and the criteria was ST segment elevation. And there's no subset or literature showing that we inadvertently treated an aortic dissection as a STEMI and cause harm. There's nothing in the literature. And those are all, if you look at all the GISI and all the initial studies, and we were just giving lytic therapy, like, you know, and so it's really unlikely that an aortic dissection is going to cause a STEMI. It's going to cause ECG changes, but it's not going to cause in general. So you have to kind of go with probabilities. And so, you know, again, I think that this lady, again, as we talked about, you open up an RV and the RV, you open up the RCA and the RV recovers beautifully, way better than the LV does. And so this is 30% chance versus 0% chance. You know, I appreciate saying we'll do salvage because I've had to beat my cardiologists at my past institution. And I would call a different cardiologist. I'll just tell you that to the crowd. I mean, if you don't like what your consultant's doing, get another one. And I've done that many a time. And I send them a bottle of wine and a basket of fruit and whatever they like. But you know what needs to be done for the patient. And you say, okay, that's not the answer I want. I'll get another one.
Well, Sarah, you said something really interesting a second ago, because I remember when our institution was part of that enormous study of like 10,000 patients where we were comparing, I think it was like TPA with streptokinase or something, like you had to have so many patients because the differences between them were so minuscule, right? So many patients in the study. But in the end, you know, that was in the late 90s and there were patients getting systemic thrombolytics for STEMIs back then, right? So this patient's in front of us. We don't want to take her to the cath lab. Of course, we are still worried about thrombolytics with whatever that is in the pericardial fluid there. So just throwing it out there, because I'm, you know, really trying to envision myself in the footsteps of this person and thinking about all these people around. Hey, everybody throw out ideas. What could we possibly do? I don't think that really probably was an option because of this, you know, material. And if we're thinking there was some sort of free wall rupture, but when would you think that you would give a systemic thrombolytic for a STEMI patient as opposed to having that patient go to the cath lab? Would that situation ever occur these days?
It has in my role, just when I find that there's longer time, right? And we know time is myocardium, and that's really very true. And so, but this is a different situation. I've got people who can do the right thing, and I can't ask them to do something they're uncomfortable with. But as we've talked about before, the level of discomfort, I've had cardiologists stand there when a patient is having a STEMI and came in VFib, and we defibrillated, and they're having a STEMI, and they say, well, she's unstable. I go, well, she's unstable because she's having a heart attack. And they go, well, she's intubated. I go, no, she's breathing. She'll wake up. She had no brain perfusion for a few minutes. Go save this person's life. Because that's kind of, and so that the feeling among cardiologists, and for all of us, I don't want to point to, but I think there's always well, what's the downside for me? And I think that, we have to focus on, we are here to save this woman's life. And I was reading this case, as I told you, Mike, I was like, ah! Let me scrub back. I can still do a cath, but anyway.
Hafeez, I guess I should have warned you that there was, you were the cardiologist, and there's a bunch of ER doctors here. Nate, tell me your thoughts at this point, and then I want to bring some of the questions from the chat in here. So, Nate, where are you at this case with you standing in the bed in the footsteps? And then we're going to bring Scott back in for some other thoughts too. So we haven't heard from you in a second. Sorry about that, but what are you doing when the consultants are thinking, let's just admit her to the floor in the ICU, and you're thinking you're admitting her to die?
Yeah, I'm with you guys. I mean, in the end, her greatest chance for survival is revascularization. That's all she's got. And if she's not a candidate for that, she's gone. And so I'm pushing on that. And the main thing that I would focus on with my communication with the consultant is reducing any ambiguity with the case. Having a rambling conversation, including all the data that you've collected, is not doing you any favors. All you're doing is muddying the waters and reducing the chances that you're going to get the outcome of interest, which is off to get this procedure done. And so including the anemia and the potassium, all you're doing is giving more fodder to not get the intervention done. So a clear, concise conversation, and I would use unambiguous language. Like, my understanding for this patient, now that we've identified this as a STEMI, we've identified RCA occlusion, my understanding is that the standard of care for this patient is revascularization. And if you're seeing something that would prevent that, what is it, and what can we do about it to get her to that procedure? And my documentation is going to be the same: unambiguous, simple, direct, to move in the direction that I think the patient needs to go.
How much do you put in, Nate, when you're talking to that consultant that you want to do something more aggressive, the patient's baseline status? In other words, she's a 70-year-old who was riding horses yesterday, or ran the half marathon or something. Sorry, Sarah. I know you sort of mentioned yourself being 65 and this patient being 70,
Right.
so I thought you opened it up to that
Here,
possible
I'm
question
totally
there.
right.
But I mean, I've heard people say that to put a picture in the room, in the hospital room, of the patient, so they're not viewed as a horizontal, unresponsive, patient, but as a real human being. And I think to all of us as physicians, sometimes putting that in. So do you do that, Nate, when you're talking to the cardiologist, sort of when you're trying to talk them into stuff, or any consultant, I should say, to paint a picture of the patient's baseline functional status?
I'm not really a touchy-feely guy, and I don't dig too deep into social history, so for me, that doesn't come up as much.
Gotcha.
My objective is, here's the data, here's where I want it to go. How do we make this happen? Because all I'm doing is potentially, downplaying a patient, adding the fact that they're riding horses and they have a new dog and they have all these grandkids. I don't know that that's necessarily going to sell them on a case that they're not interested in. But if I tell them the opposite, like, she has no reason to live, I'm definitely doing a disservice to the patient.
Okay, Scott, so I want to bring it back into the hardcore medicine here. So say we have this patient, say is just not happening as far as going, at least right now, for an interventional cath. What are some of the other things that we can do? So Dave asked about a balloon pump. You yourself talked about ECMO. What are some of those other sort of temporizing measures that we in the emergency department are able to advocate for?
Yeah, I mean, if you can't get her to the lab, then you're not going to get a balloon pump, and you're not going to get a mechanical circulatory support device. So it's kind of, look, it comes to this patient needs to either be on the OR table or in the cath lab. And, to what Dr. Hassan said, I feel so much for our interventional cardiologists. They're put in a really rock and hard place position. But in most states, and you'll have to find out your individual states' regulations, cardiogenic shock is an exception to mortality being a ding. And if you're in one of those states, you have to figure out what criteria that takes and get your patient to that point. Like in New York, you have to be on 2 vasopressors. So put the patient on 2 vasopressors to get them to the lab. I mean, there's nothing I could give you, Mike, because it's all just twiddling your thumbs as, disasters occurring. We know that what the result of this case is going to be. This patient either needs to be on a CT surgery OR table or they need to be in a cath lab. And anything short of that's just not going to fix the blockage to major vessels in her heart. So I wish I had something better to offer.
It's really interesting you should say that. That's not information that I was familiar with. And I'm sure that, and I sort of hinted around that question just a second ago to Hafeez, but we all would be probably reluctant, right, to take some if there's that risk of that bad outcome, and that'd be sort of on us in that sort of way. On the other hand, we are watching this patient die. So this whole thing of shared decision making to me sometimes feels like on the surface, I love it. But sometimes in practicality, I see it as a little bit of like not SDM, but more CYA, because it has to be shared decision making, but with our guidance. And just doing a shared decision making to say, okay, she's probably going to die, so let's just let her die, and it's just easier for everyone, is not really being true to the patient. It has to be within our guidance. And saying something like, hey, this is how I'd want my family member treated could be a very, a very powerful way to make sure that patients understand exactly what's going on. And it's sort of the other interesting part to me is I didn't really intend for this discussion to sort of move into this part of things. Maybe I could have anticipated it, but it is just sort of interesting that we sort of are at the point, Scott, just like you said, we've sort of done everything. So besides going to the cath lab or being put on a table, there's nothing really more. This is assuming that all the stuff that we've said and the 2 vasopressors and all that stuff that has been done. And obviously the CT scan ruled out dissection. So some of those reversible-ish type of causes, right?
Yeah.
Right.
So,
Mike, there's one more
yeah.
thing that hadn't been done that should be, which is if both services are going to say no, they have to do it to the patient's face. Now, interventional cardiology was there, but CT surgery needed to be at the bedside too. And then the 3 of us have to have a conversation, and you have to be looking at the patient in their eyes as you tell me that you're not going to take the patient to the OR or the cath lab. And then it gets rid of a lot of ambiguities when all of you are talking in the same room, and that conversation really should occur. It started in pulmonary embolism with PERT teams, but I think it's the way to play for any super sick patient where there's ambiguity about the best clinical decisions to be made.
Absolutely.
Totally agree.
So Hafeez, let me have one question for you that came from the, and Dave P says, don't carry the casket on your own. That's another way of saying it, I guess, right? So can you give us just a couple of things? What are the situations where a balloon pump helps with? Is it simply cardiogenic shock with, obviously hypotension, or are there other times that are the other indications to use a balloon pump? If you could just sort of say that, and then what we'll do is we'll sort of go around and everyone could give their last like 30 or 45 or 60 seconds of summaries from this case.
Absolutely, absolutely. So we used to use a lot of balloon pumps, but currently in European guideline, it's class 3. They don't use balloon pumps anymore. In American guideline, it's still 2B. We used to use it in cardiogenic shocks, typically anterior MI patients or acute and chronic systolic heart failure patients. But recently we have discovered that balloon pump can be a very good bridge to an ultimate plan. For example, if somebody is having a mechanical complication like this patient, free wall rupture or VSD, or a severe MR from the papillary muscle rupture, balloon pump is gonna help the patient with some blood pressure. Okay, it's gonna help with the coronary perfusion. and until you have time to think about the ultimate plan of the patient. For example, patient needs to go to the OR and they can revascularize it and patch repair the patient. But balloon pump can be very, very helpful in maintaining the perfusion to the brain and perfusion to the coronary meanwhile. Now, it doesn't give you much cardiac output. According to the study, it's only 0.5 to 0.8 liters per minute as compared to the Impella, which is 3.5 to 4 liters per minute. But balloon pump is so easy to put it in. It's like you open up the fridge and you get the bottle and drink it instead of going to the store, getting the Impella and putting it to the patient. So it's very accessible, very easy to put it in, and it gives you time to think about it. And these patients are very complex, no matter what you do. Even you do the surgery, there's a lot of data from Mayo Clinic. Even you do surgery in these patients, after 2 months, 80% of the people are going to die. They're very, very sick patient. And this patient, revascularization is not going to improve the outcomes. The patient already had a free wall rupture. These patients don't reach the hospital. This patient is lucky that she reached the hospital. But what are the outcomes? Revascularization is not going to open. Patch repair, it's all mushy myocardium. I haven't seen any of these patients in my clinic. Why? Because they don't survive. It's
Okay.
basically it's too late.
Okay, so let's say what happened actually. The patient got admitted to the ICU, acute inferior STEMI, pericardial effusion, hypotension, etc. We know all this stuff. And then the ICU note from the next day is exactly like you all predicted. Her blood pressure started to fall, became bradycardic, unresponsive, CPR is initiated. I mean, at that point, it's probably not going to be helpful, right? Her heart was beating and now it's not at all. So getting her back to where she was when she was dying is not really that helpful. But obviously, she'd been kept full code, which is fine, of course, got multiple rounds of medications and was pronounced dead at 6:14 a.m. So almost 24 hours exactly to when she came in. And she unfortunately had this bad outcome. And maybe, like you said, maybe that was unavoidable. For folks who want to claim CME credit, there is the QR code. I'll leave that up there for a second, and we'll put it back up in just a second after this also. I'm going to also, and then we'll come back to the CME thing here for folks who weren't able to get their phone quickly enough, to talk about next month. Again, is the June before our summer break to when we start again back in October. So this is a link for registration for Chapter 15, 81-year-old man post-arrest. So talking about some of those post-arrest best care type of scenarios. So I'll leave this up here. I'll flash it back in a second. But while we do, why don't we just sort of start alphabetical order? Nate, why don't you give us 30 seconds of take-home points from this case?
Main one for me putting this case together for the chapter was take all the data you get and apply clinical context, because we gather a lot of data on patients, CBC, CMP, there's a laundry list of labs just in those two tests. And if you don't put it in the appropriate clinical context, it's going to get you off track. And that was one of the main take homes from this case, is that they found these labs that were erroneous, and it pushed them in the wrong direction and delayed focused care for what the patient was actually experiencing.
Hafeez.
I will endorse Sarah actually. If you don't like one consult, call second person. It really helps. It has happened with me. It really helps. And the second thing is always have to have the number of the junior most cardiology colleague. For example, this patient came 1 week ago and you want to send this patient home, make sure you call your junior most colleague in cardiology, because he will be excited to see this patient within 2-3 days. Follow up.
I love the fact that I love the fact that you, as the cardiologist, say that if we don't like your consultant, call someone else. We can give you an honorary emergency medicine badge thing to wear on your badge when you go to work tomorrow. So that's awesome. Well, you're one of us now. You're one of us now, brother. Right.
Thank you. I appreciate it.
Sarah, take home point.
Well, I think I totally agree with what Scott was talking about, having consensus. And this is where you need to bring everybody at the patient's bedside and say, let's keep things focused, and let's keep our eyes on the game of doing the best thing we can for this patient. And so that's where sometimes just the face-to-face. I've had multiple situations. I have a very sick person. I'm like, I want you down here now. I don't want your fellow. I want the attending down here now. And sitting here and talking to each other. And that's saying, and saying, now you talk to the family, because we're going to say, we're going to put this patient, and her risk of death is going to be huge. And just, somebody in the chat said, don't carry the coffin alone. And I've said that many times. Just make sure that you get as many people, as many heads together to make sure you're doing the right thing for the patient. and make sure you listen to your colleagues, there's going to be a senior nurse back in the back of the corner who's you haven't listened to, will say something, you're like, oh my God, I didn't even think of that. And so this is an ED, we are team leaders. And so make sure that you bring all your team players in. I love the comment of bringing the juniorist cardiologist. I mean, my husband's an oncologist. I remember he was first going into practice and he would hang out in the cafeteria hoping he'd get business, and so this is what they need a consult to pay their mortgage. But oftentimes they're a little bit younger, hungrier, and not burnt out, and may do what you want them to do. Not necessarily the right thing. I mean, if you've got mushy myocardium, which is clearly was there, but at least you've done your best.
All right, Scott, bring it home for us.
Yeah, I want to convince Nate that premorbid state does matter. It's our major prognostic factor for so much of critical care. You show me a person that has, functional activities and they could do stuff in their life, then we're going to push hard. And there's no bigger person saying, let's not go down an aggressive route if they don't have ADLs, if they can't actually fend for themselves. So that's what matters to me. So if this is 7 years old, but physiologically, she is much younger, she's doing all this stuff, she's a Sarah, then I don't care what the age is. Let's give a full court press. And on the other hand, if they're 70, but they look like they're 90 and they can't get out of bed, I'm not going to push for them to go to the lab or to the OR. So premorbid state matters a lot to me.
Well, everyone that has joined us, thank you so much for sharing an hour of your time on this Monday night with us. All of these book clubs, except for a couple of technical ones that were technical difficulties, but all of them are available on the website, EM, like emergency medicine, so embouncebacks.com. And congratulations to the 5 trivia question winners. We will get those books out to you probably Saturday. I'll be mailing them, so I get them beginning of the week. And most of all, thank you so much to our panelists. This was a tough case, and the fact is that this emergency physician knew the second this patient got there, especially without hypotension, that this was going to be a super tough case. And you could just feel the frustration and maybe even the panic in their notes when they're trying to organize all these people to do something for this patient. And maybe she was not salvageable in the first place, but it does seem to me also take home that we could have given her a chance. And Hafeez, it sounds like you would have, at least after all these things, and especially after the CTA, knowing it wasn't dissection, you would have taken her and at least given this patient a chance. So thank you everyone so much again. And we look forward to seeing you next month and then back again in the fall.
Awesome. Very nice meeting
Don't
you.
ever say it, but buy the book. It's amazing.
Yes, we have to stop giving away, Scott, right?
That's right.
All right, take care. Thank you very much for the opportunity.
Thanks,
Thank you,
everyone.
appreciate it.